Blood gas monitoring is a central element of neonatal respiratory management because it provides precise, real-time assessment of ventilation, oxygenation, and acid-base balance. Infants with respiratory disease often appear clinically stable even while significant derangements are present. Objective data allow timely adjustment of respiratory support before physiologic instability occurs. pH, PaCO2, and PaO2 remain the core measures. pH reflects the net effect of respiratory and metabolic processes. Carbon dioxide tension indicates how effectively alveolar ventilation removes CO2, while oxygen tension measures diffusion across the alveolar capillary interface. Bicarbonate and base excess quantify the metabolic component and help distinguish primary versus compensatory changes. Arterial sampling provides the most accurate evaluation of both oxygenation and ventilation. Capillary gases can approximate pH and PaCO2 if perfusion is adequate, but do not accurately measure PaO2. Venous gases are mainly useful for trending metabolic status when arterial access is not available. Each method must be interpreted with awareness of its limitations and the infant's perfusion state. The value of blood gas monitoring lies in identifying patterns over time. A gradual rise in PaCO2 with a stable oxygen requirement may signal declining lung compliance or inadequate tidal volume. A fall in PaCO2 with elevated pH indicates excessive ventilation and risk for cerebral vasoconstriction or decreased cerebral blood flow. Interpretation should integrate gestational maturity, disease process, and current support mode. For example, permissive hypercapnia may be appropriate in evolving bronchopulmonary dysplasia, but not in acute respiratory distress. The goal is not normalization of every variable, but maintenance of physiologic stability within safe ranges. Arterial blood gases remain the gold standard for evaluating both oxygenation and ventilation in neonatal respiratory management. They provide direct measurement of pH, carbon dioxide, oxygen, bicarbonate, and base excess, allowing precise assessment of gas exchange efficiency and acid-base balance. Continuous arterial access through an indwelling line allows frequent sampling and real-time titration of ventilator settings, but carries risks that require vigilance. Thrombosis, infection, and distal ischemic injury are potential complications, particularly in very low birth weight infants with fragile vessels. Strict attention to line maintenance and aseptic technique is essential to minimize these risks. Umbilical arterial catheters are often preferred in unstable or critically ill infants because they provide reliable access during the acute phase of illness. Once the infant stabilizes, transition to a peripheral arterial line or less invasive monitoring is appropriate to reduce catheter-related complications. Because preterm infants have limited circulating blood volume, frequent or unnecessary sampling can lead to iatrogenic anemia requiring transfusion. Careful coordination of blood draws with other laboratory testing and the use of microvolume collection systems help limit cumulative loss. The balance between accurate monitoring and preservation of blood volume is a constant consideration in neonatal respiratory care. Venous blood gases are an important alternative when arterial access is limited or contraindicated. They provide a reasonable estimate of systemic acid-base status and ventilation trends without the risks of repeated arterial puncture. For clinical use, venous samples are reliable for pH and PaCO2 trending. Central venous gases, obtained from umbilical or peripherally inserted central lines, reflect the balance between tissue oxygen delivery and consumption, offering insight into perfusion adequacy rather than pulmonary gas exchange. However, venous gases cannot accurately measure oxygenation. PaO2 values from venous samples vary widely with tissue extraction and should never be used to guide oxygen or ventilator adjustments. In infants with shunting or unstable perfusion, reliance on venous samples can underestimate the severity of hypoxemia. Venous sampling reduces the need for arterial sticks and can safely monitor trends in stable infants receiving non-invasive support. Results should always be interpreted in the clinical context, correlated with pulse oximetry and overall stability. When oxygenation or ventilation is rapidly changing, arterial gases remain essential for accurate assessment. Capillary blood sampling provides a practical method to assess ventilation and acid-base balance when arterial access isn't available. The goal is to obtain arterialized blood from a warmed, well-perfused capillary bed to approximate arterial pH and CO2. The sample is drawn from a heel stick, or, in older infants, a finger stick. Because the technique relies on arterialization, site preparation directly affects accuracy. Proper warming increases local blood flow and reduces the venous component, allowing results to reflect alveolar ventilation more closely. Capillary gases reliably reflect pH and CO2, making them useful for trending respiratory status or monitoring the response to therapy. However, O2 values are not dependable. The degree of tissue oxygen extraction and local perfusion variability cause large differences from arterial measurements. So, oxygenation should always be interpreted using pulse oximetry or transcutaneous monitoring. Capillary sampling carries less procedural risk than arterial puncture and reduces the frequency of invasive line access. It remains especially useful for stable infants on non-invasive respiratory support or during recovery phases when frequent trending is needed without compromising blood volume. Accurate capillary gas interpretation depends on proper site preparation and perfusion. The sampling site must be adequately warmed, typically to about 42 degrees Celsius for 5 to 10 minutes, to arterialize the blood. Insufficient warming leaves a higher venous component, producing falsely low oxygen tension and elevated carbon dioxide values. Heating devices should be used carefully to prevent burns. Only approved warm packs or thermostatically controlled devices are appropriate. Improvised methods such as microwave towels can cause serious injury. Adequate perfusion is equally critical. Sampling from cold, cyanotic, or poorly perfused tissue yields unreliable data because sluggish flow increases local CO2 accumulation and decreases pH. In states of shock or hypothermia, capillary samples lose correlation with arterial gases and should be avoided. Local tissue integrity must also be considered. Bruised, inflamed, or edematous areas alter microcirculation and oxygen diffusion, resulting in artificially low pH and elevated CO2. Hemolysis from excessive squeezing or trauma can distort electrolytes and invalidate results. Selecting an intact, warm, and well-perfused site ensures the capillary sample best represents systemic ventilation and acid-base status. Site selection directly determines sample reliability and safety. For infants under 6 months or weighing less than 10 kilograms, the heel provides the best access to arterialized capillary blood. The puncture should be limited to the lateral or medial plantar surface and never the posterior heel, where proximity to bone and nerves increases risk of injury. In older infants or children, the site of the second or third finger can be used for sampling. The puncture should be shallow and controlled to avoid tissue damage. Bruised, edematous, previously punctured, or infected areas must be avoided, as altered perfusion and inflammation distort gas values and increase discomfort. Rotating sites reduces local trauma and maintains reliable sampling conditions. Proper technique after puncture is essential to maintain sample accuracy. Excessive squeezing or milking forces tissue fluid into the specimen, diluting gases and altering results. The flow should be spontaneous, aided by adequate warming and perfusion rather than pressure. If policy allows, the first drop of blood is wiped away to remove skin contaminants and interstitial fluid. The capillary tube should be held horizontally and filled by passive capillary action. Air bubbles, even small ones, change oxygen and carbon dioxide tensions and must be avoided. Clots within the tube can block filling and produce falsely low PaO2 and elevated PaCO2 values. After collection, the tube is sealed immediately to prevent gas exchange with air. Analysis must occur within 15 minutes. If a delay is unavoidable, the sample is placed on ice to slow metabolic consumption of oxygen and continued CO2 production. Every step from puncture to analysis directly determines the reliability of the reported values. Capillary gases provide dependable information on pH and CO2 when performed under proper conditions. They are most reliable in stable infants with good peripheral perfusion and stable respiratory support. When circulation is compromised or oxygen has recently changed, the results can deviate substantially from arterial values. PaO2 from a capillary sample should never guide oxygen management. Local extraction and variable perfusion make it an unreliable indicator of systemic oxygenation. Oxygenation should always be evaluated using pulse oximetry or transcutaneous monitoring. Accuracy can be verified by comparing a capillary sample with an arterial gas when perfusion is marginal. Consistent correlation supports continued use of capillary monitoring, while poor agreement indicates the need to rely on arterial sampling until perfusion improves. Samples should be collected only when the infant is physiologically stable or at least 20 to 30 minutes after adjustments in oxygen or ventilator settings, allowing sufficient time for equilibration. Pain control during blood sampling directly affects physiologic stability and procedural safety. Even brief, repetitive procedures can increase oxygen consumption, elevate intracranial pressure, and provoke desaturation or bradycardia. Non-pharmacologic methods are the foundation of procedural comfort. Swaddling, non-nutritive sucking, and sucrose or breast milk each reduce pain responses, and their combined use is more effective than any single measure. In breastfeeding infants, direct nursing during sampling can enhance stability and lower stress scores. Parental participation through containment or gentle touch supports autonomic regulation and improves behavioral recovery. These approaches should be used routinely whenever feasible. Topical anesthetics such as lidocaine-prilocaine cream can be applied if time allows before elective procedures, but should be avoided in infants receiving oxidant drugs that increase the risk of methemoglobinemia. Gentle, efficient handling throughout the procedure limits sympathetic stimulation and minimizes cardiorespiratory instability during and after sampling. Blood gas interpretation integrates pH, carbon dioxide content, and bicarbonate values to identify whether an imbalance is respiratory or metabolic and whether it reflects acute or chronic adaptation. The process is systematic. Evaluate pH first, then carbon dioxide and bicarbonate, always considering clinical context. In neonates, the normal physiologic range is slightly more acidotic than in older children or adults. Typical pH falls between 7.25 and 7.35, carbon dioxide content between 40 and 55 millimeters of mercury, and oxygen content between 50 and 70 millimeters of mercury. Preterm infants often tolerate lower oxygen content values due to developmental differences in hemoglobin affinity and oxygen requirements. Deviations from these ranges reflect distinct pathophysiologic processes. A low pH with elevated carbon dioxide content indicates respiratory acidosis from hypoventilation. A low pH with reduced bicarbonate indicates metabolic acidosis from excess acid production or bicarbonate loss. Conversely, a high pH with low carbon dioxide content signifies respiratory alkalosis due to hyperventilation, while a high pH with elevated bicarbonate indicates metabolic alkalosis. Compensation occurs as the body attempts to restore pH toward normal. The kidneys adjust bicarbonate in chronic respiratory disorders, and the lungs alter carbon dioxide elimination in metabolic disturbances. Distinguishing acute from compensated states helps identify whether the primary disorder is recent or long-standing. Extremes in either direction carry specific risks. Hypocarbia below 35 millimeters of mercury can cause cerebral vasoconstriction and ischemic injury, while severe acidemia below pH 7.20 depresses myocardial function and impairs perfusion. The aim is to recognize the pattern, identify the primary disturbance, and guide ventilator or metabolic management accordingly. Respiratory acidosis is one of the most common abnormalities encountered in neonatal respiratory care. It occurs when alveolar ventilation is insufficient to clear carbon dioxide, leading to a rise in carbon dioxide content and a fall in pH. The imbalance reflects impaired gas exchange, increased dead space, or depressed respiratory drive. In neonates, small changes in ventilation can have large effects because of high metabolic carbon dioxide production and low functional residual capacity. Poor lung compliance, airway obstruction, or equipment leak during mechanical ventilation each reduce effective tidal volume and promote carbon dioxide retention. Typical causes include respiratory distress syndrome, severe or evolving bronchopulmonary dysplasia, and airway obstruction from secretions or malpositioned endotracheal tubes. Central nervous system depression from intraventricular hemorrhage, sedatives, or hypoxic ischemic injury can also impair drive and ventilation. The physiologic consequences are clinically significant. Acidemia depresses myocardial contractility and systemic blood pressure. Hypercapnia increases cerebral blood flow and intracranial pressure, which can contribute to intraventricular hemorrhage in preterm infants. Management focuses on restoring adequate ventilation rather than buffering the acidosis. The first step is to verify the cause and confirm accuracy with trends and the infant's clinical state. On ventilator support, adjustments may include increasing rate, tidal volume, or peak inspiratory pressure as appropriate, while avoiding excessive pressures that worsen lung injury. In spontaneous or non-invasive ventilation, evaluate interface fit, leak, and work of breathing. Permissive hypercapnia can be used to minimize ventilator-induced injury if pH remains above approximately 7.25 and perfusion is stable. Continuous monitoring and repeat gases after changes help prevent overcorrection into hypocarbia. Respiratory alkalosis occurs when ventilation eliminates carbon dioxide faster than it is produced, resulting in decreased carbon dioxide content and elevated pH. In preterm and critically ill infants, even small increases in minute ventilation can cause significant hypocarbia because of their low tidal volumes and high alveolar surface area relative to volume. The most common cause is overventilation during mechanical support. High ventilator rates, excessive tidal volume, or excessive pressure delivery lower carbon dioxide content below physiologic targets. Manual ventilation during resuscitation or transport can also rapidly drive carbon dioxide levels down. Spontaneously breathing infants may hyperventilate during agitation, pain, or early hypoxemia. The physiologic effects are clinically important. Hypocarbia causes cerebral vasoconstriction and reduces cerebral blood flow. Sustained hypocarbia has been associated with periventricular leukomalacia and impaired white matter development in preterm infants. Myocardial contractility and oxygen delivery may also decrease when alkalosis is severe. In the past, hyperventilation was deliberately used to reduce pulmonary vascular resistance in infants with pulmonary hypertension, but this strategy is now avoided because of the risk of cerebral ischemia and secondary injury. Management begins with identifying excessive ventilation. Ventilator rate, pressure, and tidal volume should be reassessed and adjusted to maintain physiologic carbon dioxide content, generally between 40 and 55 millimeters of mercury for most neonates. For spontaneously breathing infants, evaluate for agitation, pain, or hypoxia that may drive hyperventilation and correct the cause. Stabilizing ventilation and addressing stressors usually restores normal acid-base balance. Metabolic acidosis occurs when acid production exceeds buffering capacity or when bicarbonate is lost faster than it can be replaced. The blood gas pattern shows decreased pH and decreased bicarbonate, with a compensatory fall in carbon dioxide content as ventilation increases. In neonates, the most frequent causes involve impaired perfusion and tissue oxygen delivery. Hypoxia, shock, and sepsis lead to anaerobic metabolism and lactic acid accumulation. Renal immaturity further limits the ability to excrete hydrogen ions or regenerate bicarbonate. Additional losses occur with diarrhea, gastrointestinal fistulae, or large volume gastric drainage. Clinical consequences are significant for organ function. Acidemia depresses myocardial contractility, lowers systemic vascular resistance, and worsens pulmonary vasoconstriction. This combination can reduce oxygen delivery and aggravate pulmonary hypertension. In extremely preterm infants, metabolic acidosis can also impair surfactant function and contribute to apnea. Evaluation focuses on identifying the underlying source. Laboratory assessment should include lactate, electrolytes, renal indices, and evidence of perfusion or sepsis. Treatment addresses the cause rather than the laboratory value. Volume expansion and improved oxygen delivery correct hypoperfusion-related acidosis. Antibiotics are initiated when infection is suspected. For renal or gastrointestinal losses, appropriate replacement of fluids and electrolytes restores buffering capacity. Bicarbonate therapy is reserved for severe or refractory acidemia after perfusion and ventilation have been optimized. Rapid or excessive administration can cause paradoxical intracellular acidosis and sodium load, so dosing must be cautious and guided by follow-up blood gases. Metabolic alkalosis results from excessive loss of hydrogen ions or an increase in serum bicarbonate concentration. The blood gas pattern shows elevated pH and elevated bicarbonate, often with compensatory hypoventilation and a modest rise in carbon dioxide content. In neonates, the most frequent causes involve gastric or renal losses. Continuous nasogastric suctioning and prolonged vomiting remove hydrochloric acid, leaving bicarbonate unopposed in the extracellular space. Loop diuretics such as furosemide promote urinary chloride and potassium losses, impairing the kidney's ability to excrete bicarbonate. Chronic hypercapnia in infants with bronchopulmonary dysplasia can also lead to compensatory metabolic alkalosis as renal bicarbonate retention persists after carbon dioxide content normalizes. The physiologic effects include hypoventilation from respiratory compensation, which can worsen carbon dioxide retention in infants with limited pulmonary reserve. Electrolyte abnormalities, particularly hypokalemia and hypochloremia, may cause muscle weakness and arrhythmia and further blunt the ventilatory drive. Management focuses on restoring chloride and volume balance, reducing or discontinuing gastric drainage when possible, minimizing diuretic exposure, and providing isotonic fluids with chloride replacement help correct the disturbance. When chronic hypercapnia is involved, adjustment of ventilator settings to maintain stable carbon dioxide content prevents recurrence. Direct bicarbonate reduction is rarely indicated. Normalization depends on correcting the underlying loss rather than neutralizing the excess base. Interpretation follows a logical sequence to prevent errors from focusing on individual values. The process begins with determining whether the blood is acidemic or alkalemic by assessing pH. Once direction is established, the next step is identifying whether the primary change is respiratory or metabolic. A low pH with elevated carbon dioxide content indicates respiratory acidosis. A low pH with decreased bicarbonate indicates metabolic acidosis. When pH is high with low carbon dioxide content, the process is respiratory alkalosis, while high pH with elevated bicarbonate reflects metabolic alkalosis. These patterns describe how ventilation or metabolic buffering shifts systemic acid-base status. Compensation must then be evaluated. The body attempts to return pH toward normal by adjusting the opposing component. Respiratory compensation occurs rapidly through altered ventilation, whereas renal compensation develops gradually through bicarbonate retention or excretion. Assessing whether compensation is appropriate distinguishes an acute disturbance from a chronic or mixed disorder. At the bedside, these relationships direct management. Respiratory disorders require changes to ventilatory support, while metabolic imbalances prompt correction of perfusion, renal function, or gastrointestinal losses. Each intervention aims for physiologic stability rather than perfect numeric normalization. The blood gas shows pH 7.28, carbon dioxide content 60 millimeters of mercury, and bicarbonate 26 milliequivalents per liter. The first step is to assess pH. A value of 7.28 indicates acidemia. Next, determine which component explains it. The carbon dioxide content is elevated, confirming a respiratory origin. The bicarbonate is slightly increased, suggesting that renal compensation has begun but is incomplete. This pattern represents respiratory acidosis with partial metabolic compensation. The elevated carbon dioxide level indicates inadequate ventilation. In a mechanically ventilated infant, this may result from low rate, insufficient tidal volume, or significant circuit leak. In a spontaneously breathing infant, it can occur with fatigue, airway obstruction, or central hypoventilation. The mild bicarbonate rise occurs as the kidneys begin retaining base to buffer the accumulating acid, but this process takes time. If pH were near normal with the same carbon dioxide level, that would imply a chronic, fully compensated state. Clinical response focuses on verifying ventilation adequacy. Ventilator settings or spontaneous effort must provide sufficient minute ventilation to maintain carbon dioxide content within target range. Repeat gases after any adjustment confirm whether the intervention corrected the primary abnormality. The blood gas shows pH 7.36, carbon dioxide content 28 millimeters of mercury, and bicarbonate 15 milliequivalents per liter. The first step is to assess pH. Although it falls within the normal range, it is on the lower side, which indicates a compensated process. The low bicarbonate confirms a metabolic acidosis, while the low carbon dioxide content shows respiratory compensation through increased ventilation. This represents metabolic acidosis with full respiratory compensation. The infant is hyperventilating enough to offset the fall in bicarbonate and maintain near normal pH. The primary cause lies in a metabolic disturbance rather than a ventilation problem. Common causes include lactic acidosis from hypoperfusion or sepsis, renal tubular acidosis, and bicarbonate loss through diarrhea or gastrointestinal drainage. A normal pH in this context does not indicate recovery. Compensation only masks the degree of the underlying metabolic problem. Continued acid generation or bicarbonate loss will eventually exceed the ability of the lungs to compensate. Evaluation should focus on identifying and correcting the cause, such as improving perfusion, treating infection, or replacing fluid and electrolytes. The blood gas shows pH 7.52, carbon dioxide content 25 millimeters of mercury, and bicarbonate 22 milliequivalents per liter. The elevated pH indicates alkalemia. The low carbon dioxide content identifies a primary respiratory process, and the normal bicarbonate confirms that renal compensation has not yet occurred. This pattern represents an acute respiratory alkalosis. The carbon dioxide level is low because of increased ventilation. The underlying cause is usually excessive ventilatory support or spontaneous hyperventilation triggered by pain, agitation, or early hypoxemia. During mechanical ventilation, settings that produce high rate, large tidal volume, or excessive pressure can quickly drive carbon dioxide content below physiologic range. The immediate effect of hypocarbia is cerebral vasoconstriction, which reduces cerebral blood flow and can lead to ischemic injury, particularly in preterm infants. In addition, severe alkalosis may reduce myocardial contractility and oxygen delivery. Correction requires reducing the degree of hyperventilation. Ventilator rate or pressure should be adjusted to achieve carbon dioxide content within the normal range. For infants breathing spontaneously, attention to comfort, pain control, and oxygenation prevents further episodes of hyperventilation. The blood gas shows pH 7.48, carbon dioxide content 50 millimeters of mercury, and bicarbonate 33 milliequivalents per liter. The elevated pH confirms alkalemia. The high bicarbonate indicates a metabolic process, while the elevated carbon dioxide content demonstrates partial respiratory compensation through hypoventilation. This represents metabolic alkalosis with partial respiratory compensation. The kidneys have retained bicarbonate, or the infant has lost hydrogen ions through another route, and ventilation has slowed in response to the elevated pH. The compensation is incomplete because respiratory adjustments cannot fully normalize pH when the metabolic disturbance persists. Typical causes include diuretic therapy, such as furosemide, which promotes chloride and potassium losses, and prolonged gastric suctioning or vomiting that removes gastric acid. Post-hypercapnia during recovery from chronic respiratory acidosis can produce a similar pattern as renal bicarbonate retention lags behind normalization of carbon dioxide content. Clinical effects depend on the severity of the alkalosis and associated electrolyte changes. Hypokalemia and hypochloremia worsen muscle weakness, impair ventilation, and prolong recovery. Correction centers on replacing chloride and potassium and restoring extracellular fluid volume. Adjusting or discontinuing diuretics or gastric drainage may also be necessary to prevent recurrence. Here are a few more examples. The first example shows pH 7.25, carbon dioxide 60, and bicarbonate 24. The pH is low and carbon dioxide is high, confirming respiratory acidosis. The second example shows pH 7.52, carbon dioxide 25, and bicarbonate 24. The pH is high and carbon dioxide is low, consistent with respiratory alkalosis. The third example shows pH 7.30, carbon dioxide 35, and bicarbonate 16. Both pH and bicarbonate are low, indicating metabolic acidosis. The fourth example shows pH 7.48, carbon dioxide 45, and bicarbonate 33. The pH and bicarbonate are high, representing metabolic alkalosis. The fifth example shows pH 7.18, carbon dioxide 70, and bicarbonate 30. This is a severe respiratory acidosis with partial metabolic compensation. The final example shows pH 7.60, carbon dioxide 20, and bicarbonate 18. Both pH and carbon dioxide indicate acute respiratory alkalosis with limited metabolic adjustment.